calling the meeting to order.
Yes, I'll do it right now. Do you need to warn everybody about being recorded and all that? Or
Yes.
is it right call to order? Okay, so hi everyone. I'd like to call to order this first 2025 meeting of the Health Plans Benefit and Qualification Advisory Committee meeting for Access Health Connecticut. I want to remind everybody that when they speak to first identify themselves at least a couple of times so we know whose voices to put with the comment. With that, Marcin, you want to talk about recording?
Yes, Mr. Chair, this meeting is being recorded for the minute-taking purposes, as well as for posting of the recording of the proceedings on the agency's website. This meeting is also being live streamed on the Access Health CT website. Thank you, Mr. Chair.
Thank you. Could we have an attendance?
Yes, Mr. Chair. Grant Ritter, Chair.
Here.
Thank you. Sean King.
I'm here.
Thank you. Mark Schaefer. Matthew Brockman.
Here.
Dr. Manisha Tutani, DPH Commissioner. Soon Goin.
I'm on.
Yep. Brendan Riff.
Present.
Yep. And Paul Lombardo, subject matter expert. Thank you, Dr. Ritter.
Okay, thanks. Thanks for coming. Next, if possible, could I have a motion to approve the minutes from last time?
Dr. Ritter, we have to go back to agenda item B. We did not receive any public comments.
Yeah, I'm sorry. You told me we didn't have any public comment, but
Okay.
I should have at least mentioned that. Yes, sorry. Okay, no public comments for this meeting. Okay, could we now have a motion from someone that was there for the approving the minutes from the February 20th, 2024 meeting? I know it was 11 months ago, but it's our first chance to approve those minutes.
So moved. I think I was there, Mark Schaefer.
Okay, thank you. Second?
Second, this is two.
Yeah, we got him. All right. Could we have comments or revisions or any edits, any suggestions? If not, could we have a roll call vote?
Yes, Grant Ritter.
Yes, accept.
Sean King.
Abstain.
Mark Schaefer.
Yes.
Matthew Brockman.
Abstain.
Soon Goin.
Yes.
Brendan Riff.
Yes.
And Manisha Tutani. Thank you.
Okay, thank you. Approved. Next, could we have Kelly Cody tell us about the mission, vision, and values?
Good afternoon and Happy New Year to everyone. Glad to see everybody came back to the HBBQ meeting for a fun-filled year for Plan Year 2026. As we do each year, we always go into starting off these meetings, identifying what our mission and vision and values are here at Access Health. So I'll quickly go over this information. Obviously, our mission is to decrease the number of uninsured residents, improve the quality of healthcare, and reduce health disparities through an innovative, competitive marketplace that empowers consumers to choose the health coverage that gives them the best value. Our vision is to provide Connecticut residents with access to the most equitable, simple, and affordable health insurance products to foster healthier communities. We also have 6 of our values, our core values that guide all of the work our employees do throughout the year. The exhibit identifies the authenticity, integrity, excellence, ownership, one team, and passion. With that said, I'd like to move over to the next slide. This is the certification life cycle for plan management. I'm not going to go through this entire slide, but a lot of the information on here, there's several milestones within this life cycle that this group is key in making sure that we deliver those milestones. The first milestone is to make public the medical and dental solicitations and also provide the standard plan design information to the issuers for participating on the exchange. It's important to release this information in early March so that the existing issuers have the opportunity to review the documentation, review the solicitation, and ensure that for the upcoming year, if there are any changes, that they are able to implement them within the short period of time. So once that first milestone is met, to meet that milestone, we will obviously need to discuss the certification requirements and the standard plans for plan year 2026. That will bring us to the second milestone, which is releasing of the QHP and the SADP application, and that is the finalized documentation going out to the issuers with all the pertinent information, whether it be materials and instructions for the certification process. In order so that we get that information to them on time, they can then meet the June 1st date, which is milestone 3, which is June 1st, to submit all of their relevant information that needs to be reviewed in order to be certified on the exchange. Throughout that time, we are working with each issuer, going through all the documentation, answering questions or asking questions. And so we want to take the opportunity to say thank you to the partnership. Without them and without the diligence of their associates, the process wouldn't be as easy as it sometimes is. And then the final milestone is 4, which is what we just completed, is the open enrollment and making sure that we are able to certify those plans so that for November 1st of this year, sorry, we've already moved into 2025, for this November 1st, that everything is certified and ready to go for the consumers of Connecticut to enroll in a plan. So the next slide will go over a little bit more in detail some of the actual dates. So we have received information from CMS. They've released the draft NBPP, which is the Notice of Benefit and Payment Parameters, but the actuarial value calculator and the MOOPs, the maximum out-of-pocket amounts, are actually in a finalized status, which has kind of put us in a different position this year, allowing us to start the process a little bit earlier than in the past. So we obviously have today is our first scheduled HBBQ meeting, and we have 2 other meetings scheduled, and with hopes that by March 6th, we will be able to present to the board of directors any of the recommendations that comes from this group. And that ties into our first milestone, which I was discussing on the previous screen, which is releasing the QHP and the SADP solicitations to the issuers. The rest of the milestones on this screen is really waiting for CMS to finalize the NBPP. We don't expect this year there didn't appear to be a lot of different changes, which means that perhaps the going from draft to final, there won't be any changes. Fingers crossed. The last piece is waiting for the IRS to release the HSA limits. So what we will end up doing is, as we have in the past, we will end up meeting with the board of directors as long as they, assuming they accept the recommendations from this group, and everything is smooth sailing from that point, we should be able to meet milestone 2, which is releasing the applications to the issuers that have responded to the intent to participate on the exchange. And then finally, that will help us reach our milestone of receiving any certification submissions by the June 1st date. Before I move on to the next exhibit, does anybody have any questions or on timeline? Thank you.
Okay.
So for certification requirements, this exhibit really is to outline some of the conversations that we've had in the prior year, and then suggested topics for this current year. So for 2025, we really looked at the standard plan, or actually the changes that we made was to the standard plan for the QHP products. Although we did review the SATP MOOP amounts, we did not make any changes. So for 2026, you'll see 2 check marks, and those, again, following last year, we would like to review the maximum out-of-pocket amounts for the standalone dental plan, and then to review the standardized plans for the QHP plans for 2026. Next slide, please. Before we actually get into the plan discussion, last year we had a slide included talking about health equity strategy. At that time, we had explained that we had gone to many meetings held by actuarial groups, listening to some of the CMS communications, reading documentation, and a lot of the feedback that we got from attending those meetings or listening in on calls. The main focus was that it was really about educating consumers, helping them understand how to use their plans, giving them more information so that they could make better choices. So in last year's HBBQ meeting, we had indicated a couple of items that we were going to focus in on. Under 2024 considerations, those were the things that we talked about. We said we were going to focus on commonly used benefits that are not subject to deductible, making sure that those commonly used benefits are a flat copay or perhaps coinsurance. Obviously, from members' feedback, they prefer to have a flat copay rather than coinsurance because at least they know what it is that they're going to pay as they go to, say, for instance, they go to the PCP. Their plan is a $10 copay. They know that that's what they need to pay. But in addition to that, many of the plans prior to having to pay the copay, sometimes a deductible applies. So our focus has been trying to, on the more highly utilized benefits, how can we eliminate the subject to deductible or remove the coinsurance amount? List benefits to our plan. So listing more benefits. One of the things that we heard loud and clear from our consumers is that we didn't have enough of the benefits listed for them to make a clear distinction between many of the plans that were being offered on the exchange. Even though that there were many differences, there just wasn't enough listed. And then data collection. Using analytics to figure out how consumers were actually using our website and try to help or try to use that information to make a better user experience. So what did we end up doing? In 2025, we made some significant changes to our consumer portal. We updated the portal to clearly identify for a consumer when a deductible does not apply. We had already implemented the language to identify when it did, but we thought it would be very beneficial to communicate when it didn't, because it's important for a consumer to know that. We focused in on the highly utilized services and trying to move them to a copay or eliminating the subject to deductible. Obviously, we can only do that within the parameters of what we had, but that is something that is part of our line of sight. The portal includes a larger or an expanded list of benefits to help the consumers clearly see the differences in the plans when comparing any of the plans that are offered on the exchange. And we also now have and have been gathering analytical data and seeing how consumers are actually using our website to hopefully improve the user experience in future years. So before I move from that slide, does anybody have any questions with what we've done? Or
Yeah,
Matthew does. Yes, Matthew.
thanks. Yeah, I guess before we get into it, I've been on this a couple of years now, right? I feel like we then go through these slides and we say it's, do we want to move the lab to $15 versus $20? And like, what are we doing? Or maybe we can't do it. Maybe the feds don't let us do it. But like, what are we doing? Or maybe this, before we get to that, like, can we take some time to think about how do we use these plans? We now have, what, 150,000 people here? Like, how do we use these plans to actually get people to have a primary care physician, go to that person twice a year? Like, how do we get them to invest in the things that we know we need to do to drive cost changes long term? It feels like we rely a lot on the enhanced subsidies, which are wonderful, but who knows what happens there, right? We need to be thinking about we've got a huge pool of people that we should be helping them get to care. And I'm not sure, frankly, our copay co-insurance thing it's a helpful thing, but there's probably more we can do. And I'd like to spend some time thinking about, can we redesign the plans in a bigger picture to do that kind of work, to drive to lower cost, better value hospitals or better providers? Like, what are we doing in that space?
So Matt, thank you for bringing that up, because this is something that we have been talking about over the years. Now that health insurance is more affordable, we think that there's an opportunity for us. We actually have to have direct outreach to our population and leverage our brokers to connect with their clients to ensure that they're seeing a doctor at least once a year. But this is on us, public health, the city public health, to communicate more effectively and get people to understand how to use their health insurance. As Kelly indicated, the actuary said that we got to get them to take action. And to your point, the question, how do we do that? So we have to go, for some of this population, we have multi-generational behaviors we have to overcome. My grandfather, my father, they never went to the doctor until they were sick. So in their mind, for a lot of this population, going to the emergency room, that's the primary care. So to your point about helping to address costs, just that action of going to the preventative care could do a huge impact on lowering costs for everybody. But it's the communication. We have to actually go and knock on the doors and talk to the folks and get them to take action. That's the part that gets a little dicey.
I know I got that Mark wants to chime in. I would just say I agree with you that the communication is really important. I don't think that's the broker's responsibility, but there's things we can do on plan design that create financial incentives to do that, as we've done, for example, in the state employee healthcare space, which we do pretty effectively, actually. Is in some ways we've learned a lot over the years, but there are plan design things that we can do, not just the communication packet.
Right. Yeah, we did do that. And Susan, can you comment, when we looked at last time, when
Sure.
did we walk, go ahead,
Um,
Kelly?
Thank you, James. And those are all really interesting things that are met. One of the things the state did do, I think a year or two ago, maybe, they did pass legislation requiring plans, not just on exchange, to offer some HEP incentives.
Yeah.
The challenge of our plans and the restrictions on how premium is charged, premium rates and charges versus the state employee health plan is that we could have the carrot, if you will, which is what they passed,
Right.
the incentive, but they can't use the stick. The state charges employees more if they don't complete their HEP requirements. You can't charge more for the premium than the premium rates. So it's not quite as easy, to do. And I'm sure Mark may have ideas. Over the years, we've looked at value-based insurance design, and that area has moved more towards higher value services versus lower value services. And I think you mentioned too a little bit, which the state does too, incentivizing members to go to certain providers that have better, track records. And I know some of the carriers on exchange have offered some tiered plans with different tiered pricing. So that kind of goes to your point of incentivizing, the consumer to choose certain providers based on cost.
Yeah.
Mark, basically, Matt, we have to, all hands, we have to use a multi-pronged approach to get the communication, anything that we can do. And I think the brokers, part of they get a commission every month. Yeah, I think they have some obligation to follow up with the customers, make sure they're using the plan. Again, it's an they don't have to do it, but we do doing the annual certification. That's part of the training. Remind them, please reach out to your clients, make sure they're seeing a doctor on a regular basis. If they need help to find a doctor, refer them to us, or or help them find a doctor that's in their plan, which they could do when they shop and compare on the exchange. So I'm sorry, I know that was a long-winded answer, but that is something that we have been thinking about for a while now. We thought that the state rules would have helped us out, but the premium, the punishment for not doing it, we just cannot do that. But we will continue to find new ways, creative ways to get people to go see the doctor at least once or twice a year.
I think Mark also had his hand raised.
Yes, thank you. I think like Matt, I've been an advocate for value-based insurance design to drive participation since the state's been such a leader on that in the state employee plan. And I'm familiar with now the long established limitations of what you can do and within the constraints of the exchange-based plans. I have been wondering though, as the state employee health plan has relaxed its value-based insurance design requirements, and as Medicare Advantage very publicly abandoned value-based insurance design, I'm wondering what the latest evidence suggests about the extent to which VBID both engages folks in their care in a way that advances quality, but also has, I think, the desired, cost impact that I think Matt's suggesting might be there. So I at some point would welcome an update in terms of what all of what the state employee plan has learned over these last 10 years of testing the HEP model.
And we're happy to do some more research as we've done in some past years on VBID and sort of where it's moving to. And if Julie, from an actuary's perspective, has any information to add to, we'd welcome that.
Okay. On the screen is the plan mix for the dental plans, the standalone dental plans. We have not changed the requirements for, I think, since implementation as far as how many plans are required and how many non-standard plans can be offered. Presently, both Anthem and CICI offer standalone dental plans. All of those plans are PPO based, which means it's offering in and out of network benefit coverage to the consumers. At this time, we're not recommending any changes to the permitted amount of plans in either the individual market or small group market. Next slide. Each year, CMS goes and reviews and develops the incremental changes, or it could be a decrease to the out-of-pocket maximum, which applies to the child portion or pediatric benefit only in the plans. For 2025, the amounts increased to $425 for one covered child and $850 for two or more. At that time, this committee recommended that we continue the limits of $350 and $700. And just as a reminder that there were no plan modifications implemented since plan year 2016. So for plan year 2026, CMS reviewed and has updated the numbers. They have increased the limits to $450 for one covered child and $900 for two or more covered children. What we have reached out to both issuers to ask what the value as a percent of premium would be if we were to change the limits going from the $350, $700 to the new amounts for 2026, which is the $450 and $900. And similar to last year, the amount is quite insignificant. It's less than $1 PMPM for the age 25 and under rates. So at this point in time, we'd like to discuss with you if there is any if there's any desire to make any changes to the annual limitation for the dental plan. I will tell you that as of October 31st, the enrollment in the dental plan was just over 12,000 individuals. 15% of that enrollment was age 25 and under. So I just wanted to kind of throw that out there to you. So it's approximately 1,800 of those enrollees are age 25 or under. So with that said, if we go to the next slide, this is the actual standardized plan design. It's been, as I mentioned before, it's been the same for many years. The focus really is underneath the pediatric benefits. Those of you who have been here for some time will probably notice that this standard plan design, the sheet itself looks a little bit different because we specifically broke out the pediatric benefits from the adult benefits to make that a little bit more clear for everyone. So really the focus is specifically on the pediatric benefits and the out-of-pocket maximum for those services. So I will pause there for a moment to see if there's anyone has any questions or concerns about the current plan design and the ability to change the out-of-pocket maximum.
I'm sorry, I didn't see where the $1 ppm. you had a rate schedule, but I couldn't read I couldn't determine, did you have the new numbers as well as the old? What was going on that rate table?
No. So Margin, if you could go back one slide. So the rates here are the 2025 SADP rates. They're broken out by each plan and by issuer. So these are the actual rates for 2025. And working with the actuaries from each issuer, we had asked them if they could just provide to us what they thought the impact would be on a percentage of total premium. So when you look at that percentage against the actual rate, it ends up being, the increment ends up being less than $1. So I did not put that on the screen because I was waiting for some information, and I wasn't able to put it into the presentation prior to sending it off. So last year, I think I had it on the screen. It was, I think last year it was 75 cents was the impact if we wanted to move to the maximum amount that CMS had calculated for 2025.
And I think the amount came out pretty close, right, Kelly? Maybe it was 80 cents or something, Grants, but it was still, under $1.
Under $1.
Yeah. Are we to assume that makes the premium go up by that same amount, or are they going to, raise the premium by more than that? I mean,
if we changed and increased the maximum out of pocket as we are permitted to, it would only reduce the premium by less than $1 per member per month. So the thought has always been every year, since it really doesn't make any kind of meaningful difference to premium, you're not lowering premium significantly. So why would you want to increase the maximum out of pocket?
Oh, okay. No, I got you. So this
that's what we're looking at. Right.
I was thinking this is
sorry. This is this is the maximum cost sharing.
Gotcha.
Yeah, so it would make the plan slightly less rich.
Gotcha.
But the exchange for what you potentially could save on premium is so nominal that it has not been worth it to the committee every year.
Right. Yes.
That's why we haven't changed it. Yep.
This would only lower the premium by 80 cents, but it would lower it would raise the maximum out of pocket, the maximum cost sharing by $100. So, okay, I'm clearer on that now. So it doesn't seem like it's a very valuable thing to do. I personally think we ought to just stay where we are then. Do we have anybody else's opinion here? Anybody else want to weigh in?
I'm with you.
Okay, good.
Agreed.
Okay.
Yeah. That being the case, do we need to have a potential vote to keep it the way it is, or?
I think that's what we've done in the past.
Yeah, I think that's what we've done in the past.
Okay.
Just have a vote.
Could I have a motion then? Right. Could I have a motion then to keep the 350, 750 as our maximum, or as our limitation on cost sharing?
This is Sean. So moved.
Thank you. Seconded?
Seconded. That's Mark.
Okay. Any other comments or, suggestions? If not, Martian, could you take a roll call?
Grant Ritter,
Yes, accept.
Sean King,
Yes.
Mark Schaefer,
Yes.
Matthew Brockman,
Yes.
Tun Goen,
Yes.
Brandon Riff,
Yes.
and Manisha Tutani. Thank you.
Okay, is that all we have for? Oh no, we have more. Okay, thank you.
Nope, I got a couple more.
Great, go for it.
So before we hand it off to Julie, I have two slides here for the QHP plans. One, this is just explaining, again, similar to the standalone dental plans. This is for the QHP identifying the required amount of plans, whether they be the standardized plans or the non-standardized plans. At this point in time, we are not making any suggestions to make changes to the plan design, or excuse me, the requirements for how many plan designs an issuer may provide. At this point in time, no issuer has exceeded the amount or the maximum amount of plans that they may offer through the exchange. The next slide is just an update for the group to demonstrate what's going on in the exchange, on the exchange and off the exchange landscape. Obviously, Anthem, CBI, and CICI plans have been highlighted in yellow where it says on. For the individual market, for plan year 2025, we had a total of 22 plans that were offered, all being either HMO, POS, or PPO plans. In the small group, Anthem is the issuer, the sole issuer in that market, and we have six plans. What was new in the small group market was the added platinum plan. All those plans were PPOs. So not a lot of big changes as far as what is being offered on the exchange from year to year. So with that said, I'm going to hand it over to Julie Andrews from Wakely.
Hello, everybody. Looking forward to and working through the new benefits for 2026. If you go ahead and advance the slide, this is just sort of a high-level agenda of what we're going to be talking about, the regulatory changes, what's happening in the calculator, and show you some of the proposed plan designs that we've already developed for 2026. On the next slide is the list of different elements, regulatory elements that we need to comply with. As Kelly already mentioned, the HSA rules are the only one, along with the NBBP, which should be out shortly this week, that are outstanding. And then also mentioning that we have also that each issuer we go to test the AVC calculation of the proposed plan designs, as well as compliance with mental health parity rules for to ease the process with the filing that occurs with the Connecticut Insurance Department. So on the next slide, these are some of the elements of the plan designs that are changing for 2026. The allowable maximum out-of-pocket cost sharing is increasing from $9,200 to $10,150, as well as various increases in the cost sharing reduction allowable maximum out-of-pockets for 2026. As we mentioned, the HSA rules will not come out till May of this year, and so what we are doing is using the 2025 rules, which are a minimum of $1,650 for the deductible and a maximum out-of-pocket of $8,300. And so with these being still proposed, there's always the chance that final adjustments may need to be made when final rules are delivered. We just also want to recognize the Covered Connecticut program that started in July of 2021, and just mention that, you know, the impact of the Covered Connecticut program was not incorporated into this analysis. So there's no changes, program changes that I'm aware of defined for 2026. But so the environment for Covered Connecticut does not impact the cost sharing for those individuals who are eligible for the program. It does impact their cost sharing. However, it doesn't impact the development of the actuarial value for definition of the 2026 standard plan designs. So the next slide talks about how the federal actuarial value calculator has changed. There is no change to the underlying data for 2026. Last year, they did update the underlying data to be the 2021 Edge server data, but this year they're just taking that same data and trending it forward for an additional year, and that additional year is 6.4% of the medical costs and 10.1% of the pharmacy costs will be used to trend forward. And so the results of using these two tables provide a summary of the prior year's actuarial values and the actuarial values for the current 2025 plans by metal plan and cost sharing reduction variation using the 2026 calculator. And the numbers presented are the feedback that we got from the issuer's own analysis. And so each metal tier is defined by a range of the allowable actuarial value as produced by the Federal Actuarial Value Calculator tool. So as you can see in the first table in the top row, it defines the metal level. And the second row defines the allowable actuarial range. So for example, for a silver plan, is allowed to have an AV of 70 to 72%. And you can see from the third row that the current year's AVs fall within the range, but the plans using the 2026 calculator in red font are outside the range. So we have one plan that's just above that 72% threshold by 0.01%. And so the current 73% cost sharing reduction variation shown in the second table also fails. At this time, we did not evaluate the 87% and 94% CSR with the issuers because of the number of proposed plans that we were having them test and evaluate, and any changes often tied to what's happening with the 73% AV CSR plan as well as the standard silver. So let's go on to the 2026 plan design overview. We have had all of the issuers look at the actuarial value calculators, and though it does mention that here on this slide that they have not all reviewed the mental health parity compliance, we did get the feedback subsequent to release of the slide deck. So just some notes and caveats. So the actuarial value tool is a limited set of kind of key service categories that are used when evaluating the actuarial value. But this table shows that there are just several other categories that are defined in the standard plan designs, but are not necessarily a consideration when calculating the plan's actuarial value. The next slide is also just some plan features and notes about the plan designs as far as, you know, their most incident will be providing, showing and demonstrating a single deductible or single member out of pocket where the family limits are always 2 times. Preventative services are always provided without cost sharing. And then there are some statutory specified cost sharing limits for therapy services and for diabetic cost services that have specific cost sharing limits, and those are in the appendix. So let's go ahead and move on and talk about the first plan, and that is our gold plan. So the column on the left is the benefit categories that at a high level impact the actuarial value calculator. The second column is the current 2025 plan. And the next 3 columns are 3 additional options that we had the issuers all test. So as we noted, the gold plans did pass actuarial value under the current plan, and so no plan change would necessarily be required. However, in response to the mental health parity testing with updated data, we are aware that potential changes need to be made to the gold plan to bring the plan into compliance with mental health parity testing rules. that may be achieved without impacting the actuarial value. And so we need to go back and work with the issuers on that. But just for your reference on the 3 different options that we could consider for 2026, we looked at option 1, which included a change in the primary care copay, increasing it to $25, and also adjusting the different pharmacy copays, increasing them slightly to $15, $40, and $65 for non-preferred. The second option focused specifically on just the deductible and the maximum out-of-pocket, increasing, the deductible from $1,200 to $1,800, but then, and also the out-of-pocket, increasing it from the $7,375 to $8,500. Option 3 took a look at what if we did a mix of those type of changes, doing the deductible, the out-of-pocket, and looking at some additional copay changes, and that is what option 3 is.
Do we want to discuss these right now, one at a time, or do we wait till you've presented all of them and then discuss them? I'd sort of like to do it one at a time because they're fresher in our minds here.
Yep. So
With
Grant,
that-
yeah, I agree. Why don't we stop and take a look at the different approaches and see what the feedback is as far as updates to the goal.
If I hear you right, there's, because of parity, mental health parity, there's not much chance that the 25 plan design will hold in 26. It'll violate the parity requirement. Is that what you're saying?
Yeah, based on communication with the issuers, there will require some changes. So either we will need to change something from a copay to deductible. It may be something that is not, as I mentioned, an actuarial value element as shown here, but it may be one of the other categories that I referenced in the slides prior to. I just recently received that feedback, and so additional discussions need to occur. So I think for these purposes, it's what approach do you like directionally?
So we can either make everybody pay a little bit more for primary care and their drugs, or, I mean, everybody that has a gold plan, or we can allow the maximums to be higher for the deductibles. The medical deductible and the out-of-pocket maximum could be higher. It's kind of a trade-off. Do you get the masses of people each paying $5 more for their primary care visits, or do we sort of, those that are kind of have higher costs, we kind of say, okay, yeah, you're going to have higher costs yet. I tend to think, I mean, my own preference would be for the first, option 1, but I would like to hear what other people think about the alternative, raising the maximums in the deductible.
I would say I'm a little more in the category of 3. I like keeping, I don't know, maybe I don't know how much this does, but I would try to keep generic at 5, and maybe you move the preferred brand to 40 and non-preferred to the 65. But I don't know if that does very much, if that's a trade, but I'm more in that kind of camp of.
But if you take option 3, you think a little creep in the deductible and actually a bigger 10% increase in the maximum is okay.
Yeah.
Okay, so you're hitting the people that have already sort of got the high end anyways, and you're making the end a little bit higher.
Yeah.
Yeah. Okay. What about everybody else? I mean, obviously there's a sort of a trade-off here going on.
What does the research tell us today, if there is any, on the extent to which a 25% increase in the primary care copay would materially affect folks accessing services when they're needed versus waiting and potentially ending up in the emergency department or whatnot?
I don't know. It'd be
I don't have any direct statistics as far as, if you change it by 10%, this is what happens. If you change it by this percent, this is, that it would go down. For preventive services, they're always, free of cost sharing. That is something that we could take away. It could be something where we could look at, a change to the specialist copay as well, instead of looking at the primary care copay, if the group has a concern with regards to that change. But, one of the things that we did do heading into this year's analysis is the Access Health team did do a survey of standard plan designs offered in other state-based exchanges, as well as what is being available on the federally facilitated marketplace. And for the most part, the cost sharing that we're proposing, is in line, with the marketplace.
And that's true for both the primary care copay as well as the option one proposed increases in pharmacy.
Yes.
I don't know if Kelly can speak. Yeah, I think, Mark, our copays were lower. I think pretty much across the board was what they saw. Our copays for some of these. So that's why we were thinking about just the $5 increase as still pretty nominal for a potential change.
I'm furiously flipping through some paperwork, but after taking a look-see at what other markets were doing, at whether it be on the FFM or through other SBEs, in some instances, our copays were lower than in some of the other states. And that's why we did take the approach of just going up the incremental, like $5 and $10 on the pharmacy pieces.
And how long have we been at the 2025 levels, $20 for primary care and the tiers, the current tiers for pharmacy?
For pharmacy?
I'd have to look back, but I would say it's been several years. Most of the changes that have been occurring in the past have been tied to the lab services and the deductible and the maximum out of pocket.
So I would, I'm not sure where my preference lies at present, but it would be useful if we had data that shows the extent to which there are changes in care seeking that are a result of past increments. It seems to me easy enough to look at, if we went from 15 to 20, what that meant, if anything, for ED visits and primary care visits, and the same with regard to bumps in pharmacy. The numbers, looking at them, and even though I've been on this committee for a couple of years, they look like they probably have been at that level for quite some time. So maybe that's not a comparison that can be made. I don't have huge objections to the $25. I just prefer to understand better how price sensitive those services are for this, economic segment of the population.
Mm-hmm. Yeah, and if you flip to the next slide as well, there's we added an element of looking at. Oh, I'm sorry.
The next option you meant? I don't.
Did we take out the cost sharing? Was there one in between? The premium impact?
Yes.
Okay, never mind then. Yeah, one of the things that we were looking at with the issuers as well is how each of these might impact the premium, just to understand, since the subsidies may be going away or are scheduled to go away in 2026, we wanted to look and see, what that impact might have.
Yeah.
And to answer the question with regards to when was the last time the pharmacy co-pays were changed, I've gone back to 2020 and they were at these levels. I can't see 19, so they may have changed in 2019 to these values.
That's helpful. Thank you.
Mm-hmm.
So it seems like option 1 and option 3 are something to still continue to pursue for the gold plan. And then also just getting some additional feedback on specific studies about copay cost sharing and utilization of different services like primary care and potentially generic drugs.
I think Sean had his hand raised before. I don't know if he had a comment.
Okay. Well, if there are no further questions, we can move on to the silver plans. So we did, again, something similar. We are, the silver plan will require changes for 2026. And we took a similar approach of, doing an option 1, a slight increase to the primary care physician copay from $40 to $45, as well as an increase to the generic preferred and non-preferred copays on the pharmacy side. Option 2 does a mix of them. Option 3 still does an additional mix, but with with a lower deductible option. So for example, option 1, we're going from the 40 to 45 with the $20, $50, and $75 copays. It looks like we have 2 minutes left. I'm not sure how the Access Health team wants to continue.
I'm sorry, this is a problem, but I have a hard stop at 3 o'clock, so I really need to go then. I suppose you could keep talking after I leave, or we could pick this up next meeting if that's what people would like to do instead. Certainly, with regards to the silver plans, it looks like 1 and 3 are again sort of based on our sort of observations about the gold plans. Those would be the 2 that we want to sort of think about further.
Okay. Well, these all pass mental health parity, as well as the bronze options presented. And so what I guess we'll do as a takeaway is focus in on options 1 and 3, do revisions to the gold plan. We need further adjustments that need to happen to the 73% CSR, as well as development of the 87 and 94% CSR for our next meeting on the 29th.
Great.
And I guess as the committee has questions or is able to review this slide deck further, reaching out to Kelly or Susan with follow-ups.
That sounds good. And
perfect.
Yep, and we'll see what kind of research we can get to on the points that were raised about value-based design and, encouraging people to seek primary care and preventative care.
Mm-hmm. Okay. Okay, next meeting. So could I have a motion to adjourn?
So moved.
So moved.
Okay, seconded?
Second.
Roll call?
Ground Raider,
Yes.
Sean King, Mark Schaefer,
Yes.
Matthew Brockman,
Yes.
June Goen,
Yes.
Brendan Riff, and Manish Tutani. Thank you.
Okay. Thanks, everyone.
Thank
See
you all.
on the 29th.
Thank
now.
you.